Hey, good afternoon, everyone. Can everyone hear me? Yep. So welcome to the webinar for National Standards for Palliative Care Malaysia implementation. So before we begin, I will just cover some house rules before we start the webinar. So ensure that your full name is displayed for recording of attendance purposes. So please remain muted during the presentations. We would like to minimize the interruptions. There will be later Q&A sessions that are dedicated for asking and answering questions. So we will be using the chat box to be asking questions. And throughout the webinar, you are encouraged to use the chat feature to share your thoughts if you have any regarding the webinar. And also please note that the session will be recorded and published to our YouTube channel. And lastly, just want to inform that there will be no MMA and CPD points provided for this session. And with that, I will now pass the time to Ms. Prita, who is
Thank you.
So Ms. Prita, Ms. Prita is the pharmacist from IKN. She's the key member of the standards committee who will be moderating this session.
Thank you, Waliong. Good afternoon, everyone, and a very warm welcome to our webinar. It's great to have such wide and varied representation. I think people are still trickling in as we begin. And I think for many of you, you'll be hearing about this work, the National Palliative Care Standards, in more detail for the first time. What we're sharing today is really, it represents work that has been unfolding over the last 5 years or so. I think the Cindy probably can agree that we started this officially in 2020. And it really involved many conversations, multiple iterations of what we're putting in. And I really mean multiple. Going to the printers can be one chapter by itself. And a lot of commitment from people who care deeply about the quality of palliative care here in Malaysia. And I think it reflects what not just us, the development group, but a wider group of stakeholders whom you will hear more about in a little bit, what we believe good palliative care should look like. So today is the first opportunity for us in the development group to share more openly about the thought process behind it, the insights, how we shaped this whole thing. And I think importantly, today is also about starting a wider conversation on how we might take this work forward. And we hope to do that process as well in as thoughtful and collaborative a manner, and also in a way that makes sense for the different realities of the various service types that we have here. So it's really encouraging to see that wide mix of participants have signed up, both from public and private hospitals, a lot from hospices, long-term care facilities, I saw some, and other community services. And our hope is really then that this standards becomes an initiative that people feel a part of. And it should be something that evolves with feedback and with learning. It should be something dynamic and not something that is parked on a shelf somewhere in our offices. I'd also like to take a moment to just acknowledge the other members of the standards development group who have worked tirelessly behind the scenes over these last 5 years. And I believe a few will be joining us today online, so welcome to them. And if time allows, I think we would very much welcome your reflections and insights as part of the discussion today. We're also pleased to have colleagues joining us from outside Malaysia. And I think maybe not everything might be transferable and our healthcare systems would differ, but I really hope that there will be some aspects of today's conversations that might resonate with you and could be useful. And we are grateful for your presence with us today. And I'm going to stop there because the heart of today's session really lies with our speakers. And these are two people who have put immense thought, care and commitment, not just into the work, but also into this afternoon's sessions. And it is my distinct pleasure to introduce them both at this moment. And I'm going to be careful and read this out. So we have with us today Dr. Sylvia McCarthy, a senior palliative care physician from Hospice Malaysia, who oversees home-based palliative services, and she is active in clinical care, education, and research, not only in Malaysia, but also in the Asia-Pacific region, especially through the Asia-Pacific Hospice Palliative Care Network, including work in Myanmar, Thailand, and more recently, helping make important, meaningful inroads in Timor-Leste. And within our development group, Dr. Sylvia is the one who often gently and elegantly makes us pause and take a step back from indicators and systems and invites us to really consider the patient experience in all of this and what care looks like beyond the hospital walls. So I think she's someone who brings balance, reason, and elegance to our discussions. And she will begin by taking us through the what and the why of the National Palliative Care Standards. The second speaker this afternoon is Dr. Cindy Teo, a consultant palliative medicine physician and the head of the palliative medicine department at Hospital Selayar. Her work, experience, and training is vast, and it covers service needs and quality indicators, amongst other things. She moves seamlessly between clinical care, leadership, policy, quality improvement, and always with good, strong momentum. So if I may borrow from cinema, she's someone I think who operates everything, everywhere, all at once. But thankfully with more structure than what we have seen in the movie. This afternoon, Dr. Cindy will take us through the discussion, the journey of consensus behind the standards, and then help us to reflect a bit on how we move from this vision towards action. So I hope this afternoon we all gain a clearer understanding of why the standards matter, some insights into the journey that helped shape them, and how they might be used, adapted, and taken forward. So with that, I'm really pleased to hand over to Dr. Sylvia to begin with the first talk.
Thank you, Preeta. Can everyone see my slides?
Yeah.
Yes, okay.
Okay, thank you very much. And that was a very beautiful introduction to the work that we've been doing and the hopes that the committee has for how this is going to move forward. My job, as Preeta said, is to try and put the case for why national standards for palliative care matter and are important. But I want to start, as Preeta did, with thanks to the committee, and I've just named them all here. I won't read out the names, but just pause a moment to let you look and tell you that they are all busy clinicians who have given very generously of their time. And of course, we're not the inventors of the idea of national standards. I think probably Australia was the first. And there were also the African palliative care standards for standards of care across Africa. And the Singaporean, they call them guidelines rather than standards. And our work has benefited hugely from all this work that's gone before. In particular, Singapore very generously said, don't reinvent the wheel, just look at ours. And Patcho has been full of really helpful advice and support on this journey. And I'm aware that many other countries have standards as well. So we're not unique. But it made me reflect on my own journey with standards. And the reason I tell this story is because I think it taught me the essence of how standards should be something very supportive. And this goes back to 2010 when WHO wanted to look at to what extent do palliative care services reflect decent care values. I'm not going to try and explain decent care values, but just to say that it required a self-assessment to measure different components of the service against these values. And that was initially quite a scary thing to do. After all, how well are we doing? But having done the self-assessment, the WHO advisors sat down with us and they asked us really useful questions of why we're giving the answers we're giving. Had we thought about what data we had to support those answers? How would we present evidence that shows that we really are doing something? And where do we think the gaps are in our service. Overall, we came out feeling better than we thought we would. And we identified a big gap, which was our support for carers. It resulted in us doing a qualitative study to ask our carers what it was they needed. And the answer was practical information and help of a practical kind, more than emotional support. And so with that, we developed the Carer's Guide, and we're still using an updated version today. So it was a really useful, helpful exercise that helped us move on, and I think gave us some sense of how we've continued to work and think about improving our service. So I became a big fan of standards. Of course, there are macro level measures, the quality of death index. I'm less of a fan of that. In that it's measuring very broad concepts, and it measures us against each other. Where are we on the scale? As opposed to the Global Palliative Care Atlas, which looks at identifying areas for improvement, and so gives us a platform to think about how we need to move forward. But the standards are not at macro level. This is about policy. So we're at micro level. In other words, we're thinking about the journey of our patients. At the moment, they could receive care in many different settings, in a government hospital, a private hospital, the local pharmacy, GP, clinic kesehatan. All of these are settings where patients with palliative care needs might present, and the care that they will receive can be very hit and miss. So the standards are really important to try and create a more unified journey. This is trying to show how patients could access care if everything goes smoothly, if transitions of care are well thought out, and the services providing palliative care are all talking with the same voice and have similar processes. We also have evidence that there's a huge divide between urban and rural availability and accessibility of palliative care. And we hope, beginning by strengthening existing services, will also provide the impetus for developing more services. And we have evidence around what patients want at the end of life. There are a lot of studies, I've picked just one of them, that looked at how patients prioritize care. And of course, a lot of it is around managed pain and managing pain and symptoms. So broadly, why do we need palliative care standards? Well, patients and families need to know that they will receive quality care, that they will be able to receive a quality care in any setting, and that they will be able to be supported through their transitions of care. And these are all embedded.
Dr. Sylvia, I'm so sorry.
Yeah.
Sorry, Dr. Sylvia. It's breaking up. Is it only for me or to the others? The audio is breaking up a bit.
Oh, sorry, my audio is breaking up.
But I'm not sure if it's the same for the others. It's my connection then. Just checking.
On my side, it seems okay.
Okay, all right then. Sorry about that.
All right, okay. Are we all right?
Yeah, go on.
Yeah, okay. I think the final thing is about the common language for palliative care. At the moment, people speak from different backgrounds with different ideas about what palliative care is. So it's no wonder that patients and families are confused about what care they could expect, and what kind of care that they need. What the palliative care standards do is provide for all services to be talking the same language and to be delivering palliative care. The difference being only where you're receiving the palliative care, not what you're receiving. And how can they help? Well, the standards are very much focused on patient-centered care. And even as we go through the self-assessment, does it make sense? Do these standards help us provide the kind of care that our patients need and want? As I said, they are evidence-based. And as in the original standards that I went through, they can provide a structure for quality improvement. They can identify gaps in the service. They can suggest what we can do to improve the service. And with the data that we collect, we can advocate for more resources for policy changes. Which palliative care services should participate? All of them, anywhere where the patient receives palliative care. Initially, we want to start out with the Class C providers, and those are people whose job is 100% palliative care. So that's the hospices, the community palliative care services, and the hospital palliative care units. These are the people who spend all their time caring for patients and have the most expertise, both in terms of what patients want and need, but also in already providing care. In the future, and I'm talking in a few years' time, we hope that also other services where palliative care patients present will have worked out how to best care for those patients who provide to them and will join the standards. So the Class B provider are those who routinely have considerable number of patients with palliative care needs. And an example would be maybe the cardiologist who sees many patients with heart failure, oncologists, of course, and neurologists, and so on and so forth. I would put family medicine in there as well, because a significant number of their patients may have palliative care needs. The Class A providers are those who quite rarely see patients with palliative care needs. And it really speaks to the idea that palliative care needs to be a central part of medical education, and in fact for allied healthcare workers as well. They don't need such depth, but they need to know the basics of a palliative care approach. So what do they look like? This is the book designed by Dr. Aaron. And these are the domains that it covers. So patient care, caregiver support, staff and volunteer management, and safe care. I've tried to break them up. So patient care, there are 7 guidelines. Not all the guidelines will refer to be relevant for every level of service. So timely identification is in fact more relevant to the services A and B, because it talks to the need to identify patients with palliative care needs. And in the book, you will see an explanation of what the guideline is about. There will be the evidence for why this is important, and we know that there is important evidence around early identification of patients with palliative care needs. They need to be, if palliative care is to be effective, it needs to start early. And there is a tool that is suggested, which is the SPIC tool. So similarly, for something like goals of care discussions, we know goals of care discussions are important in providing good quality care. And the tools suggested are REDMAP and the Serious Illness Conversations Guide to help people think about how they have goals of care discussions. Those are just some examples. So the next domain, caregiver support, has really only two guidelines: caregiver support, grief and bereavement. Staff and volunteer management talk about trained staff and volunteers. How do we identify the competencies our staff need? How do we ensure that they get the appropriate training and that that training is up to date? And of course, self-care. Staff and volunteers need to be supported to develop resilience. And much of that is actually with good mentorship and making sure people are up to date in training and understand what they need to do. And finally is self-care, safe care, which is around accessibility and use of opioids and clinical quality improvement. It is not supposed to be seen as hurdles, much more as a supportive steps to get all the services to really engage with quality improvement that makes meaningful difference to our patients. The next steps are implementation. How do we start out? And we're really at the point, and Cindy is going to go into this, of thinking about it. We want to hear from everybody about how they think it might apply to them. It's a team activity. And in our individual services, it needs to be a team activity. There may be one or two core leaders, but everyone who's involved in delivering care and patients and families should be able to give their opinion. Of course, we need to read and get to know the standards and think about their relevance to our individual services. And please, please, please give us feedback. When a service feels it's ready, they can volunteer to have a go. It is not mandatory. The advantage of doing it is just to know that you're using something that will enable you to improve your service in line with what other services are doing. It's about self-assessment, and at the end of a self-assessment, you should be able to identify particular guidelines where quality improvement initiatives will be useful. And of course, we need to evaluate the outcomes from quality improvement initiatives. Services won't be on their own. There will be a team from the National Palliative Care team who will support services through this. And again, the national standards present tools that can help in quality improvement.
Thank you, Dr. Sylvia. So I think that sort of lays the groundwork for us, and it's a nice, clear framing of why standards matter. I liked hearing your personal experience as well. And I think for me, key, and I think with the development group throughout, is that it's not meant as, rules, but like a shared foundation. And I think we're very keen on seeing how it supports what is already there on the ground. I think this is important. So from the pre-webinar questions as well, a lot of people are asking about how this might be relevant, how this might work, in hospice settings and all. And I'm just going to, stretch that a little bit more and ask you, how do you see these standards being different from, policies and guidelines that are already there? And especially for a service that might think I'm doing well, what then is that incentive or that impetus for me to take this on voluntarily?
Thank you. I think the standards work on the assumption that if you're involved in palliative care, you want to give the best care possible. And that sometimes it's difficult to know whether you're doing that. And sometimes it's difficult to think about how to improve because we're all working in quite an isolated way. And now there is a book. I'm hesitating to say book because it's online.
At the moment.
Yeah. That can give some structure to that is all. So that it will be something for services to read, to think about, to familiarize themselves with, to think about, do we fulfill some of these guidelines? And it's evidence-based. It's not a single person's opinion. And as you said, it's entirely voluntary. But
and
we
then,
hope that services, the desire to take part is because we care about patients and their families. Does that answer the question?
Pretty much. I'm just thinking from the lens of like we have all these documents, then we just don't want this to be something else that's parked somewhere. Right? So I think we'll go more into that as we listen to subsequent discussion talks. Was there anything in this development process that maybe surprised you about, palliative care services here in Malaysia in general? What we learned through this whole exercise of doing it, or what did it tell you about our current state of palliative care here?
In a way, I think that's going to be the next step forwards as we talk to different services about what the standards mean to them and how they see it playing out. But the process of our meetings and discussions certainly showed how important it is to have stakeholders from all services, right, because the experiences in the group were very different.
And I believe, we had patient voice in there as well, which you advocated for very strongly. And I think that's so important, like keeping the patient at the center of this whole document and indicators that we're talking about, ultimately get it to them. I don't see any other questions in the chat box. Perhaps we'll leave it at that for now. Dr. Cindy, if you're ready, I'll let you have the floor there.
I'll share my screen then. Okay, just checking that my slides are clear.
It's fine.
All clear?
Okay, thank you. So good afternoon, everyone. And I'm just really excited to see so many people joining the webinar today. Thank you for being here. And I see many familiar names and faces as well. So my name is Cindy, and I am a palliative care physician based in Hospital Selayang. And I've been given the task to explain how we have developed the standards. And to me, it is as though we are painting a picture, and we are painting a picture of consensus. So Malaysians are rojak, right? So are our palliative care services. Our Malaysian healthcare landscape is very heterogeneous, very, very different. And so when we started out on this project, we were like this palette, distinct, separate, vibrant, but not quite yet a coherent picture. We had very different hues, different resources, different funding, different realities and feasibilities. And so the challenge for us was, how do we paint one national picture, one national standards, while maintaining the unique color of each provider? So by the end of this session, I hope to do these few things. Describe the multi-stakeholder approach to the development of these standards, explain to you how the Delphi consensus research was done. And in the second part of my talk, I will illustrate the standards as a shared framework for service improvement and advocacy. So we are familiar with this paper. Sylvia shared it just now, and many people have seen this work by Mala and her colleagues, which clearly shows the disparity of services across our country. And we know in Malaysia, palliative care looks very different depending on where you are, ranging from the specialist unit in central KL to an NGO-run home visit, maybe in Sabah or Sarawak. It can look completely different. And this diversity is, in fact, our strength. But it also creates a massive challenge. We talk about the logistic difficulties, but then what about the quality? What about the standards? What does good care actually look like? And are Malaysians really getting access to a reasonable standard of care wherever they need it, whenever it is needed? And here is where the standards come in. So the standards to me is an attempt to address a national problem, to improve quality and to improve access to good care everywhere across the country. So in 2019, the National Policy and Strategic Plan identified that we needed a unified vision and a shared language to define good quality care across all settings, whether it's from Kelantan to Kuching to Kedah. We needed a common language also to advocate, because without a definition of quality or standards, we simply cannot ask for resources to improve it. So who were the people involved in developing the standards? Who were the painters? And the answer is a lot. And as Sylvia mentioned, we didn't reinvent the wheel. We didn't start with a blank canvas. We actually already had a sketch that you can see in the slide. And at this point, I would want to say thank you again to Dr. Patricia Neo and the Singapore Hospice Council for their generosity in providing us expertise throughout the standards development journey. So they gave us a sketch. But many of you here in the webinar today, the local palliative care community in Malaysia, you shaped the standards, you gave the sketch depth and color. So just to show that the formal standards subcommittee was appointed under the Research and Standards Technical Working Group, and this committee reports to the National Palliative Care Development Advisory Committee that is chaired by the Medical Deputy DG under KKM. You have already seen the names of the standards committee. Now I'm going to show you their faces. Okay, there we go. The 10 of them, wonderful people who I had to look at very, very frequently over the last few years. At the later stages, we were joined by a research team from Monash Malaysia University, and I think Mankit is actually in the webinar today. So these are the people who worked really hard to draft the standards and to create or to run the Delphi research to get the expert consensus. Oh, these are the names, which you have already seen earlier on. So thank you, everyone. So what actually happened? It was a really, really long process. 5 years is quite long. So, well, it actually started at the end of 2019 when we first did our literature review, looked at all those international standards, and we decided then that we needed to form a subcommittee to look into the development of standards. And that happened in 2020. However, COVID happened. And so nothing happened for almost 2 years. And so by the end of 2021, we started work again. We had regular online meetings and we engaged with Dr. Pat Neo in Singapore. After, I think, a whole year of monthly meetings where we discussed and debated the standards, the first draft of the standards was completed by the first half of 2023. And it was then that we decided, rather than just having external reviewers sit in a meeting room to discuss and agree to the standards, we thought that we wanted to pursue a research-based Delphi study. So that, using this rigorous methodology, we can ensure that the voices of all our stakeholders were heard. And so after we cleared ethics and registration hurdles, we actually started on data collection by 2024. And the whole process took about a year, such that we completed data collection in 2025. And at the same time, concurrently, we started preparing the implementation guide. So now, the book that you have, or the PDF that you were given, is actually a two-in-one. It's both the standards document as well as the implementation guide. And we made the decision to actually combine these two books into a two-in-one book. And I will explain in my second half of the talk how to use it. So we launched the standards in early October. And the plan is then for the next 5 years to do some implementation. And by 2030, we will have to review the standards document again because it would have been 5 years. So this is the timeline of the development. And now I'll zoom in on the Delphi study and how we did this. Now, the document going into the Delphi study was just the standards document without the implementation guide. And Sylvia has already explained there were 4 domains, 13 standards or guidelines, and 49 statement indicators. And the Delphi process was on the 49 statement indicators. And I'll show you what we mean. So these are the 4 domains with the standards in each of the domain. And I will take standard 2 as an example, reducing barriers to care. In that particular standards, there are about 6 or 7 statement indicators. And so 2.5 says the service provider has protocols for responding to palliative care emergencies or urgent needs. So you can see that the statement is simply a statement to say that, yeah, this is the expected standard of care that services need to be seen doing. And so the standards document really just creates this vision, this picture of what good quality care should look like. So they are simply statements. I won't go into this because Sylvia has already explained. And so in the early stages of implementation, we will really only be looking at Class C providers, who are the ones who solely care for palliative care patients. And these are the specialist palliative care teams in hospitals, in the community, as well as inpatient hospices. So let's go on to the Delphi method. So to me, the Delphi method is a bit like glazing or layering in watercolor. So in watercolor, you don't get the final picture in just one stroke. You add on layers, you let it dry, you add another layer, and you keep repeating and increasing depth to the picture until you form your perfect masterpiece. And the Delphi method to me is something like that. So everyone knows LUT, Kampong Boy, right? So in round 1, just giving you an illustration, the picture is a little bit blurry, it's a little bit basic, but the essential structure is there. And so in the early rounds of the Delphi, we might have disagreements, we might need to change the content somewhat, but we don't throw away the canvas. Instead, what we do with each subsequent round is that we wait, we listen, we adjust the tone, we add more depth. Layer by layer, round by round, we keep making changes and listening to our stakeholders until consensus emerges and the picture is completed. And for us, this was round 4. So another reason that Delphi was chosen was because we wanted to make sure that all voices were heard fairly. We didn't want a situation where we have a meeting in the room and we argue until the loudest voice won, because that tends to happen sometimes. And another key feature of the Delphi is anonymity, where participants can disagree with whoever, whether it's senior consultants or MOH officials, without fear. And this ensured honest feedback. So next, I will move on to the technical aspects of the Delphi methodology. So we employed a classic Delphi methodology where we adapted and contextualized the Singapore guidelines to fit our local setting. And so we individually assessed 49 indicators for both relevance and feasibility. We also tried to recruit a very diverse Delphi panel And this included healthcare professionals, representatives of civil society, and policymakers, all with at least 5 years of experience or involvement in palliative care. In round one, so once we have all the indicators ready, the statement indicators ready, we input that into round one, and we ask the panel to rate the indicator relevance on a 5-point Likert scale with optional free text comments. And the consensus was set at 80% agreement, which is a rating of 4 or more on the Likert scale. And so we gave the panel about 4 weeks to respond with intermittent reminders. Now, the data then was analyzed, and we presented aggregated results in percentages, medians, box plots, and we also summarized qualitative comments to revise the indicators. Anonymity was maintained for both the panel and the responses, so that everything was anonymous and treated equally. So feedback of both the quantitative and the qualitative elements were then given back to the panel. So with this, we move on to round two, and this is an iterative process. It means that it just keeps repeating itself, where the panel now re-rated the revised indicators. And indicators that achieve consensus for relevance would then be pushed into round three. And now in round three, we would do an assessment for feasibility. So initially it was about relevance. Is this a relevant statement? And now, is it possible to do this feasibility? And so this same iterative process was continued for 4 rounds, in our setting in 4 rounds, but usually it just keeps going until we achieve closing criteria for consensus and stability. The reason we split the rating for relevance and feasibility was due to the feedback that we got during piloting. So our participants actually pointed out that while they might agree that an indicator was important or relevant, they questioned if it was actually feasible in on-the-ground service delivery. So this is the methodology. And next, let me describe the Delphi panel, who we recruited. And this is really important for any Delphi study because they determine the quality of the expert consensus. So we had 46 participants, and they represented all the class providers, A, B, and C. We also tried to ensure a balanced mix. And so you can see about half come from hospital-based services, and up almost 40% from community settings. And the remainder were caregivers and policymakers. And we felt that doing this in our setting actually balanced expert opinion, which is the Class C providers, with real-world service provision perspectives. And we also intentionally included geographical diversity as well. So we sampled, or we had people in the Delphi panel from all over the country to ensure that we had proper stakeholder representation. So this is the Delphi panel composition in detail. And you can see that we have quite a variety of specialties that are represented here, from oncology all the way to cardiology and then primary care. One thing that was really remarkable about our study was the amazingly high response rates. So we had 4 rounds, and usually there is a very high attrition rate. But we actually found that we had between 90 to 95% response rate. And this really shows very, very strong engagement and interest in this project. And at this point, I must say a big thank you to many of you out there in the webinar, because many of you from the Delphi panel are actually here today at the webinar. So thank you for your interest and your engagement, because this is a really quite amazing engagement from the Delphi panel. So you're probably wondering, what were the results? So this is round 1 results. It's a very busy slide because there are 49 indicators. Remember that the consensus percentage is 80%. So anything less than 80% is in red. This means that these are the indicators that are at risk of being kicked out of the standards document. So in round 1, what we did then was to look at which indicators scored low. And I've circled indicator 2.4, which is the indicator regarding 24-hour palliative care provision that only had 63.6% agreement. And so when we analyzed the free text comments, the qualitative comments, we realized that they were not talking about relevance. They were actually talking about feasibility. And so we then used the free text comments in the Delphi to revise all the indicators. And we also reminded our panel that this was about rating relevance and not feasibility. So as a result, when we moved the round 1 results into round 2, all the indicators achieved over 80% agreement, and therefore all the indicators moved into round 3 for feasibility. And so you can see in round 3, there are much less red marks in there. And so we really only had 3 indicators that did not achieve consensus. And these were related again to the 24-hour service provision, one on quality improvement frameworks, and another one on holistic assessment because of concerns regarding delivering psychological and spiritual care services based on our current healthcare infrastructure. And when we looked at the results, I mean, we understood that because we understood that many public hospital services had already quality improvement frameworks, but NGOs, you know, with sustainability challenges, really felt that doing all these things would really not be feasible. And we get that. We understand. We can see where the struggles are coming from. And yet, when we again gave feedback to the panel to show them that, look, these are the indicators that are at risk of getting kicked out. And when we reiterated that the study goal is of minimal yet aspirational standards, the round 4 results actually showed that all 49 proposed indicators passed. So they actually all got achieved more than 80% consensus. We note that there were lots of concerns about feasibility expressed, you know, right in round 1, and this continued through all 4 rounds. We understand that this really shows that there will be potential challenges in incorporating these standards in our current healthcare system. But what it also showed us, and actually it really surprised us, because we were ready for some indicators to be kicked out, but we were really surprised for the high levels of agreement. This is quite rare in a Delphi where nothing got removed and everything was agreed on. Despite, you know, so many people expressing concerns about feasibility, but they still passed the indicators. And this to me shows that, you know, there is a very, very high level to a commitment to service development and excellence in patient care. And this certainly augurs well for palliative care in Malaysia. What it does mean is that for the future steps, the next steps, when we talk about implementation strategies, we need to be very careful, very mindful of the situation on the ground, continue to take in stakeholder input to ensure that the adoption of the standards will be successful. So look at this image. I think everyone knows that this is the famous Children on a Bicycle street art in Penang. And that artwork only works because the artist collaborated with the street by using a real bicycle, the real texture of the wall. And I think our standards document are the same. The standards document can only work or will only work because they are built on the real world reality of our sector. The consensus that we achieve through the standards committee, through the Delphi process, means that this document is a collective ownership. It is not an MOH directive, even though it's parked under MOH. It is actually our own vision, the palliative care community, and it is our definition of service excellence. So just to summarize that, this standards is a co-created national art piece. It has scientific rigor, it's layered with local reality. We have been careful to use the Delphi process to make sure we layer on evidence and get expert feedback. To me, it's a ladder for growth, not a hurdle, like Sylvia said. It is designed as a framework to help us identify and advocate for resources and to climb towards service excellence together. The question, of course, is how do we then take this collaborative work, you know, off the wall? How do we use it effectively to improve care in a feasible manner? So how do we do that? So perhaps that's something that we can explore somewhat in the next session, but I would like to stop at this point to take any questions. And maybe I can stop sharing.
It's like radio silence in the chat box that I was wondering for a second if it works. So it's either, I don't know, there's some confusion out there or things are really, really clear. And maybe to just help it along a bit, I'm going to ask Dr. Sylvia, please feel free to chime in as well. What perhaps then engaging with this document really looks like. Maybe it's seeming a little bit abstract. I'm not sure because we've been sitting with it for a few years now. But maybe for people listening to it, teams listening to this for the first time, how is this really relevant? And perhaps coming from a service that wants to engage with its standards, what might be some first practical steps in the coming weeks or months, and maybe that will help it along.
Okay, maybe I'll go first. The first practical steps, right? The first thing to do is to download it and read it.
Sure.
And it is a little bit scary because it's 136 pages. It's quite a lot, and although we tried to make it as simple as possible, I think it does look quite daunting. And so I would say, look at the domains, pick one that stands out. That, you know, if you have had, you know, issues with caregiver support, if it's been on your heart, then you might just want to zoom in on standard 8 and 9 and to just start with 1 or 2 and have a read, and do tell us. Actually, what we would really appreciate is feedback on how usable this is, how usable it is. Does it make sense to you, or does it just confuse you? Because to me, I think this document is a live document. We will be changing it, we will be tweaking it as we go along, so that when we do revise it in 5 years' time, you know, it might look quite different. Because right now it looks like, yeah, very much like the Singaporean version. So we'll be very happy to have our very own Malaysian version based on feedback.
Dr. Sylvia, any thoughts before we?
I think Cindy's really said it. It's kind of read and digest. Think about maybe an area where you think your service is doing really well. Look at one of the standards. Think about what evidence you have to show you're reaching those standards. Those are the indicators. And then maybe look in one area that you think maybe I'm not doing so well. Or just the one that sounds like today you feel like looking at it.
So I think that's helpful, yeah. So you do not have to take that document as a whole and look at achieving everything on it. And in fact, I think that brings me to thinking about what does perhaps, you know, even if you don't meet everything, or it's not like a pass or fail thing or a yes or no question sometimes, but then what might indicate that you're actually moving in the right direction, even if you were to take one indicator and work with that, for instance, but you might not be actually accomplishing what we have set out as an indicator, but what could be encouraging or tell the team that, no, this is going all right.
I suppose that's where, you know, if you're not doing well with one guideline, so what is that about? Is it simply that you don't have the data there to support, and do you need to collect the data? And once you collect the data, you can say, yes, look, I've got the proof. Or is it actually that it's part of a service that you don't deliver yet, and you maybe want to think about quality improvement? And once you've decided what it is or how you're going to improve it, evaluating whether that worked or not, whether it's made a difference for your service, your patient group. And at the moment, that's as far as we want to go. In the future, services might share and data might be shared, not by name, but by aggregate results. And you can see where you're doing in the national picture, but nobody else can.
How much do you, oh, sorry, please carry on.
Yeah, so initially, and for the first few years, it is about looking just at your own service and evaluating within your own service what you do.
And who in the team do you think is best positioned, or what kind of support might help the team to bring this thing forward or make it alive within your service?
Do you want to take that, Cindy, or shall I?
Yeah, I think once we have more implementation strategies to suggest, we can maybe answer that better. But at the moment, it really would be anybody who is interested in quality, anybody with leadership skills, I suppose, because there needs to be some leadership in that. But the main thing is really interest. And I want to link that to what Adnin has asked in the chat box. Is there support for services who want to improve their standards but don't quite know how? And we are forming a working group to come up with strategies and also support. So we haven't actually have a very clear picture of what that's going to look like. But in my vision, in my head, I would see a lot of peer support. So peer support as well as support from the working group. So it will be vertical and horizontal support. And we need to come up with that structure.
I'm seeing a few more questions in the chat box speaking to that, who would sort of own this thing within the service, who might help to bring that forward. And I think those are important questions to address. And Chong Kam Pui, Pei-Wen. Hi, Pei-Wen. Pei-Wen has asked, where do we even start? Who might be the best person to kickstart? And where do you even start with something like this?
And so this is a quality improvement activity. And so if you are in a hospital service, sorry, just again speaking with my KKM hat, and Sylvia's going to frown at me.
That's why we need her.
Yeah, that's why we need her. And if you are in a KKM service, then actually there are lots of QA activities going on. And so this would be part of quality activities. And so the standards will easily fit into whatever quality activities that you can do. There's a whole range, isn't it? Clinical audits or QA or whatever. But for self-evaluation, probably it will be related to the people who are handling QI in the various palliative care services. So usually there will be somebody who is elected or a team.
And I want to get to the questions. Oh, sorry, Dr. Sylvia, did you want to add?
Yeah, I just talking with my hospice hat. It would be a general discussion with the team, who's interested, who feels passionately about this, who's got some concerns in a particular area, and you might rotate. But as Cindy also said, somebody with leadership skills who will kind of keep on top of the process.
Can I also mention that? Yeah. Sorry, can I also mention that you would need to have support from management, or the leadership team. Yeah. So in a setting like ours, the head of department needs to be involved, because you need to get buy-in. Because quite often when you do any quality improvement, there might be changes to the structure, to policies, and it can get very frustrating if you feel that you're doing it all alone and nobody's listening to you. So you do need to get buy-in from management and all that. Yeah.
It is very much a team exercise, both within the service and outside of the service. So that there will be a team outside the service to support as well, who are not coming to tell people what to do, but to talk through the process.
And I think you actually voiced what's in my mind as well. And possibly a starting point is getting those right voices in a room to begin with, and to look at it and to pick out certain things. And support from the higher ups, crucial. Support from management and how you bring that forward. And I do want to get to the questions in the chat box, but because I think, Dr. Cindy, you sort of baited me with talking about quality improvement exercises, audits. Did you mention audits perhaps and all? And I think that is a huge concern. How usually it's one person championing it and pushing things, and and it almost becomes a checklist. How do you think we can avoid that happening, especially as we go through? We want this thing to be sustainable. So how do we prevent, or at least minimize, this implementation from just drifting into like a compliance checklist almost, and being something that's engaging with the multitude of other audits and things that we have to comply to out there, for example?
the heart of it is why do we even want to do something like this? And if we can remind people of the why, which is to improve patient care and deliver patient-centered care, I think very few people in palliative care will argue with you. And you can see from our Delphi results, you can see that people felt there were lots of challenges to even having a document on standards. People were concerned that we were even outlining what is considered quality of care, and yet despite so much concerns about feasibility, people still said that no, this is important. And it really comes back to quality of care, making sure that our patients get what they deserve. And so if we frame all these activities as just that, just doing what we want to do well, because I think every single person here wants to deliver patient-centered care and good care, not just care, but good care.
And I think in a way that speaks to Punita's question of why have we made it voluntary self-assessment instead of being mandatory or external evaluation. Precisely because we want this to be a meaningful exercise. We want it to result in better patient care. We don't want it to be simply an exercise in generating yet more data that gets dusty somewhere. And I think sometimes when you're forced to do audits and collect lots of data, it's easier just to sort of make it up a bit as you go along. And it doesn't really have meaning at the end of the day. So we would prefer people to want to do it and just to do it well for themselves, not for anyone else, for themselves and for their patients.
Yeah, that's speaking to the motivation, right? If there's an intrinsic motivation to get something done, I think that will make it more sustainable than depending on external motivation, which is when something is mandatory. Yeah. Can I very quickly answer Ronnie's question? Did we include Sabah? We definitely included Sabah. There is more than one. I actually can't count how many there were from Sabah and Sarawak. And so they represented East Malaysia. So we did represent, and we did hear, I think in our qualitative comments about some of the rural-urban divide. And so those viewpoints were taken into consideration.
And I think in terms of going forward, using the standards, that they are flexible enough to apply everywhere.
I actually wanted to ask a little bit about that, like how much, what looks like a reasonable amount of, flexibility or adapting it to meet different contexts, or what might just turn into avoiding it completely, perhaps, like that balance.
I think that's the feedback that we will need as well. While we think that we have consensus and that these are flexible guidelines, we've yet to see how they work on the ground.
Yeah, and I look forward to seeing how that pans out in the piloting. So hopefully we can see how these standards look like on the ground, and so we will be able to answer that maybe in a year's time.
And the team is also concerned, right, that we don't go in or research it from that very auditing type of a perspective, but more of an open, like a learning, like more of a learning process, really, and open questions to do that. Just before we go to your last talk, Dr. Cindy, sorry, if you have any thoughts about how we might encourage teams to really honestly reflect and know without creating that, sometimes it's hardest to look at yourself and what you're doing, and you might think you're a really good service. And then you have these things here, and as Dr. Sylvia said, people might want to just tick that I have accomplished this. How do we do that without creating that fear or defensiveness, perhaps? Any thoughts on that? Either one of you, or is it? Oh,
a hard one to answer.
Yeah,
I'm sure.
Communication, and it's about what do you want to achieve for your patients, not to be able to sit around saying, I've got this score, what did you get? If
Mhm.
you like. It is very much about what you want to achieve within your service, and the conversations around, well, was that a helpful exercise or not? But not really comparing outcomes as yet.
Can I also add just some observations? I mean, we've just launched this in October and it's about 2 months. And I think the development committee, the standards development committee, we were a bit apprehensive, isn't it, about the response that we might get. And we just assumed that there will be a lot of negative responses. But can I just say that I've not received any?
Are you surprised?
I am
Surprising?
actually very
Okay.
surprised. And in
Okay.
fact, the kind of comments I've received are, where's the document? Can I have a copy? How do I use it? And so the flip side of the coin is that there are actually many services who are excited about this, who are wanting to use it. But of course, we are also conscious that there are services who might be on the other end of the spectrum. And so I think we will have to have conversations with them to try and understand what are some of the reasons for being apprehensive, and try and be as supportive as possible.
Great. There is one question by Dr. Adnin, which I'm not sure, Dr. Cindy, would you like to talk about this in your upcoming talk, or asking about outcomes that we hope for, you see, in shaping behavioral changes?
We can keep that for the end. Do you think we
I
can
thought
just
so.
bookmark that, and then we can have a
Certainly.
discussion right at the end, and maybe we can even invite people on the floor to contribute to that in the spirit of engaging our stakeholders. Yeah.
Yeah. Thank you all for some really nice, great questions and the discussion. I'm going to invite Dr. Cindy now then to proceed with the last talk.
Is it working? Are my slides okay?
Yeah, it's good.
All right. So this is the second half of my talk, and it will be shorter. So I'm going to talk a little bit about implementing the national standards for palliative care. Although, like I've mentioned earlier, we don't really have a clear strategy yet, and this is very much a work in progress, where we want to then translate or transform this vision that we have of what quality care is to action. And this is really the crucial part of the work that we want to do next. And so what I will do in the next 15 minutes or so is to describe how to use the national standards document as it is now, and the accompanying implementation guide. We also want to explore and take a look at how other countries have used standards to drive improvement, and maybe get some ideas from them. And also propose the phased implementation roadmap for Malaysia, the big picture idea that we have. We don't have the minute details as yet. So in the last talk, we looked at this finished art piece, right? The national standards for palliative care. Let's continue with this painting metaphor and think about how do we achieve those standards, or how do we paint this similar picture? Now, every artist knows that before the paint hits the wall, you have to actually look at the wall, right? We have to look at the wall. Where is my picture? Yeah, we have to look at the wall. We have to see the cracks. We have to look at the texture, the space that we have to work with. Now, I see the standards document as a tool to help us do that, to help us reflect and look at ourselves. How is that so? Let me explain. So the standards document is a bit of a how-to manual. And just to recap, there are the domains, the 13 standards, and the statement indicators that look like this. And I said before that the document is a two-in-one book. The first part is the standards, and the second part is really about how to implement these standards. let me use one of the standards to illustrate the Part 1 and Part 2 concept. So let's look at Standard 12 on the accessibility and the use of opioids. So Part 1 is the vision, right, the standard. And so if you have the document with you and you happen to have opened it, look at Standard 12, okay? The standard statement is, it's very small. Patients with palliative care needs should have access to opioids for symptom control with guidelines and processes in place to ensure safe and effective use. Then we go on to explain the rationale, why that is so, and we give relevant references, which if you scroll down, you will find the references. Next, we move to the statement indicators. And in this particular standard, there are 4 statements. And let's look at 12.1 and 12.3. So 12.1 says that service providers caring for patients with palliative care needs should have access to opioids. And 12.3 says that there is evidence of patient and caregiver education on the effective and safe use of opioids. Now, these are the indicators. These are what services should be doing. Then there are suggested tools to then help the services do that. And so that might be either guidebooks or websites or instruments or even questionnaires, all sorts of different tools to help you achieve that. And so this Part 1 just talks about what quality of care looks like. Then Part 2, which follows on immediately after that standard part, is about how to do it. And this is the implementation guide. And so this is broken down to each individual statement indicator. So in this case, it's 12.1. So for each statement indicator, we will then have explanatory notes, what is considered good practice, the suggested measurable indicators, and tools and resources. A little bit of a repetition, but we have designed it such that if you pull out the book and you just pick out one indicator, it should be self-explanatory. So you don't have to keep flipping the pages. All right. So in 12.1, we look at patients having access to opioids, right? And good practice will look like maintaining an adequate stock of commonly used opioids at all times appropriate to whatever level of care, SOPs for prescribing, storing, dispensing, and administering opioids, and making sure there's timely access to opioids. So not just having it, but timely access. And so this could be on-call systems. So this actually articulates what we mean by access to opioids. And then next, under suggested indicators, these are then indicators that help you show evidence that you are complying or that you indeed have good practice. A bit like what Sylvia shared about the little audit that she did at the beginning of the first talk. And so you show evidence. So do you have a drug formulary that shows you have opioids? When we talk about patient information leaflets, then do you have those leaflets, for example? So those are all examples of showing evidence that you have complied with that particular statement indicator. All right, so Part 1 is the vision. So what is quality of care, related to opioid access? Part 2 is how do we then do it? What is considered good practice? And how do we then show evidence that we're doing this good practice? And this process continues throughout the entire standards document for each individual standard and each individual indicator. So that's the macro of it, right? But then we ask ourselves, right, how do we know we're doing okay? Preeta asked, if we just do 1 or 2 indicators, does it still mean that we comply to the overall standard? So eventually, if we want to know whether we are complying to the overall standard, then we would need some way of seeing ourselves through the mirror, right? And this mirror would be a self-assessment workbook. Now, this is something that is akan datang lah. It's not there yet. We are trying to develop this and getting input as we develop this. What we do have is a reference document from Singapore. Right, so this is Singapore's version of the self-assessment workbook, and I have extracted guideline 12, which is the access and use of opioids. And so let me just show you what I mean. So here it says, again, it's access to opioids. So 12.1.1, they asked, does the service provider have policies and workflows for access to opioids, including out of hours? And so as a service, if you are the person tasked to do the self-audit, you will answer yes or no. And you will say, how do you know? And so this could be a service policy document, for example. What about this one? There are processes to ensure that opioids are given in a timely manner as prescribed. So how do you show evidence for this? Do you do it or not? So if you say yes, then perhaps you would say, oh, I have an on-call roster, which means that there is access to opioids 24 hours because there's an on-call roster. Example. And then there are also certain indicators that need to be measured in terms of percentages. So there will be a numerator and a denominator. And so services will take like 20 case notes perhaps, and they will calculate their percentage, that how much do they achieve that. And then they will rank them themselves according to categories. So if they never achieve it, it will be 0%. If they often achieve it, it's 50 to 75%. And perhaps there is a unit that always achieves this, and that's 100%. And again, mention where is the data source. So this is an example of a self-assessment workbook that Singapore used, and I think Thailand and Australia did the same. And they, at a national level, they measure all the indicators in the standards book. So that's one way of using it, right? And so since we're talking about other countries, let us take a look at how these other countries are using standards. And I would like to acknowledge Dr. Pat Neo and Dr. Sriveng because these slides, some of these slides belong to them. So in Australia, they have this thing called the National Standards Assessment Program. And actually, I think their standards were set like in the 1990s. And so they have decades of experience in quality improvement and using their standards. So I think the key words here are that even their NSAP cycle is a 2-year self-assessment cycle. It is voluntary, continues to be. They emphasize on continuous quality improvement, where the cycle starts with services voluntarily signing up and committing to the self-assessment cycle. They do the self-assessment, and then they have to come up with action plans, improvement action plans. And you might say that, oh, but I really don't know how to do it. And so there will be a program of support vertically and horizontally, and they really emphasize on peer mentorship, that they emphasize on this thing called the communities of practice. So then services actually group together and help each other on in their continuous quality improvement. So this is what Australia has done and is still doing. Right. And so while this is aspirational standards, it's continuous, it's voluntary, it's a 2-yearly self-assessment cycle. The quality assurance activity is very much internal, and it is under the individual organization's governance. So they sort it out themselves internally, but with a lot of peer mentorship and support from Palliative Care Australia and NGO. While we have said that it's voluntary, there is some expectation from funders, accrediting bodies, and even health services that palliative care service align to this. Because if you say these are your standards, then shouldn't you really follow this? So voluntary, but there is an unspoken expectation. Now, what about Thailand? So you can see that they use the same wheel as us. It's very similar to what we have. Nobody reinvented the wheel. Now, what Thailand then did was in this project where they looked at, I think, 12 different services, they found that they could use the data both on a local level as well as at a national level. So look at service number 3, for example. By doing the self-assessment, they could actually identify very clearly which standards that needed improvement on. It was standard 2 and 9. So as a service, they could very quickly identify the gap in their service and perhaps focus, and maybe that particular service wanted to focus on improving standard 2. And so you don't have to improve everything at one go. This simply helps you prioritize where are the areas that need improvement. Now, on a national level, and this is of course anonymized data, at one glance you can already tell which are the areas that are not performing so well. And so from a national point of view, they could very quickly identify that Standard 9 was something that they needed to allocate resources, funding and support to in order to develop. And this was in the area of grief and bereavement. And so utility at a local level as well as potentially at a national level. All right, looking at Singapore now. And so their milestones of standards development is quite similar to ours because we have been referencing what they've done. So they came up with a strategy in 2011, the policy and national strategy. And then 4 years later, they published their first guidelines or standards. They then developed their interpretation guide or our implementation guide. And then they piloted the self-assessment workbook the same year. And by the end of 2015, they actually had the full set of the standards, the implementation guide, as well as the self-assessment workbook. And now Singapore also uses a 2-yearly self-assessment cycle. So everyone's kind of doing what Australia did. And partly because they find that it is effective. Now, how is it effective? So again, looking a bit more closely at Singapore's example so that we can learn. Assuming that this is Service X, because everything is anonymized, right? And they managed to pilot 11 services. And so what is the percentage of patients with improvement in moderate or severe pain within 24 hours or by the next visit? Now, one service was very brave and they said never. 0%, never. So they never achieved this. And there were 6 units that said that they always achieved it, 100%. Now there's a red asterisk here, which indicates Service X. So the service that actually is reading this report. So what Singapore did was they collected the data, analyzed it, and put it like this in a sense of a national benchmark. But there is no cutoff. They're not saying that everyone needs to achieve 75%. No, they're just saying this is how everyone performed. I'm putting the red asterisk there to show how you perform. And they kind of left it there, ... Do what you think is necessary. So say if I'm Service A and I'm that one here all by myself, probably they might want to consider trying to make some improvements in this area. And so this was how they started off when they first piloted all this back in 2015. Now they've come a long way since then. And this is an example of how they have used data from 2 time points, right? And at a national level. So at the local level, people can do whatever they want, but they look at data at the national level. So they looked at the often and always, and they calculated the percentages of, how many people are achieving this, because I guess they felt that this is considered okay standard. So they have decided some kind of benchmark, right? So in 2015 it was 63%, and 2 years later when they repeated the self-audit, it was 80%. And so to them that was considered, okay, some kind of improvement. To take things further, look at this quality measure of whether there is a response protocol in palliative care emergencies. So when they first did the audit, only 1 out of 11 services had it. 2 years later, that increased to 40%. But they still felt that this was unacceptable. And subsequently, after this audit, they had a national level. They kind of identified that this is a low-hanging fruit, that every service really should have emergency protocols. And so then they had a strategy to make sure that services develop these policies and protocols. So a very simple quality measure, I think, because this is not a very difficult thing to do. So coming back to our Malaysian shores, what do we plan to do? So we are in 2025 now, and we are preparing. We hope to do some kind of piloting by next year, and in a year, in the following year, we hope that we are ready to upscale. If not, we will continue piloting until we are ready. And perhaps if we pilot in 2027, then 2 years later, we might have a second time point results where we can then do evaluation. And the other reason for that is for planning that we need to do in 2030. Let me explain. So right now, we are having ongoing stakeholder engagement. We have this introductory webinar right now. We are in the midst of trying to pull together a working group that represents all the stakeholders. And so we still are in the progress of doing that. And hopefully we can appoint this group by January. Piloting, we hope to be able to do this by the middle of next year. And if possible, to include a component of research as we have done with the Delphi. And then once we are ready, we will do national level implementation in one form or another, and some kind of evaluation after 2 years of implementation. And the data that we generate from all of this, from whichever services that voluntarily do this, we will use this to identify gaps and opportunities. And this will be input into our next round of national policy and strategic planning, which is due for 2031, because the current one ends in 2030. And so we will use real on-the-ground data to help us plan strategically for the development of palliative care in the next decade. So just to say again that the national standards is a co-created shared vision of quality palliative care in our country. And implementation tools, once we develop them, and they are still being developed, it should be a mirror for internal reflection and growth to enable all of us to embark in a continuous quality journey. And we are joining the global movement of standards-based care because we need to advocate for better patient care. And I invite you to join the conversation, join in the work. You can email myself or Sylvia. This is our email addresses with any questions, comments, and we will try our best to clarify things and respond to you in a timely manner. That's all I have.
Terrific. I just wanted to add on a little bit, Dr. Cindy, that we hope to park some resources for support in possibly the MHPCC website or some other common platform that people could use as a resource tool as well. Because we did not take Dr. Adnin's question, it seems to have been upvoted quite a bit. But just before that, there were some pre-webinar questions by services that sound, of individuals who sound that they might be a little bit ad hoc, or they're thinking of starting up palliative care. And we even have representation here today from homes and all. And I know we're talking about not focusing on this group yet. We're talking about the specialists and Class C type providers. But how might this still be relevant to them? How might they use this document or start thinking about their own service for those smaller settings and not something that's very formalized or structured? Dr. Sylvia, please feel free to join.
Or maybe I'll just give a very short comment. Firstly, thank you. Thank you to the nursing homes and all these other new services for thinking about standards and quality right from the beginning. And I think that's a wonderful start, that if you're setting up something new, you're already thinking of how can I do it the best way possible. I think you're well on your journey to what we're talking about. So thank you for asking that and for your interest. For those who are not Class C providers, so we have said that nursing homes are Class B. If you look at the document, in the standard page, it does say which indicators are applicable. I'm sorry I didn't mention that earlier on, but it does tell us which indicators are for Class A, B, or C. And so perhaps you could look at the indicators that are relevant to your service, because there are some that we would consider only necessary for Class C providers. And they could start with that, looking at that and seeing how it applies to them.
Sure. Okay. Would you like to take a stab at the question on behavior changes that might come about, that we hope to bring about by talking and practicing standards? And I think this could, this could be a service thing.
Yeah.
More proactive symptoms and conversation. It could be a team thing, a culture thing. Please go ahead, Dr. Sylvia.
I think it is precisely about that. It's hopefully a document that people will find useful and that will generate interest and change the way we think about making changes to our services, that it will provide some structure for that. And yes, a cultural change, that it is something that could be doable and comes from inside the service, not from outside. So I think that many services would really love to improve and would love to change. But we do sometimes work very isolated and there's no clear pathway. And I think this document provides that. So I hope it is seen as supportive. And I think if you look at what's happened in other countries, it's changed the language around palliative care delivery, and it has sort of morphed into something that's just automatic.
So when you say, are we doing the right thing for the patient, that becomes routine, right? It's not it's not an exceptional thing, something unusual to have said. That would be excellent. Dr. Cindy, any thoughts?
I find it difficult answering that question because it presumes that I understand the current behavior. And so my question actually to that question is another question. What is the understanding of the current behavior? And so I think that's my limitation coming from a KKM setting, coming from an internal medicine setting. The language of quality is very much ingrained in our services. And so in a way, the standards just gives me more fuel for my fire. So we basically continue doing what we do, but we actually have a reference document now to help us design our quality activities. But I must admit that I do not understand the situation on the ground as well as Adnin or Sylvia. And so perhaps you are hinting at something else that I perhaps don't understand. And so I don't really dare to answer that question in case I've interpreted it wrongly. Yeah.
I think personal experience and that micro perspective does go a ways as well, and hearing from different stakeholders. And I would welcome others from the development group, perhaps, because these are things that we did grapple with in the process, to share your thoughts in the chat box, perhaps. Who owns this at a national level, really? Is there somewhere that, we're going to park this data, or people own it, I guess, perhaps? And I have heard people, clinicians and such, mixing it up with KPIs, for example, and thinking that because we have standards, therefore you need to implement certain KPIs, which sort of seems to tie in with the standards better. So.
First statement, this is not a KPI.
Yeah. So
there is no cutoff, as I've illustrated using the Singapore example, right? When they first started using it, there's no KPI. So it really is about continuous improvement. At the moment, the way we are structured, the development and even the working group will all be appointed by KKM. So for now, we will be parked under the Ministry of Health. In terms of data ownership, if we can get a research, if we can get research in, basically the data will be anonymized and it will be published and it will be available for all to cite and to use. And so that's actually part of the reason that we want to incorporate research into this. Then that kind of helps with the data ownership, because then it becomes research data. But it is a longer term question that we need to address in the working group, whether this continues under the Ministry of Health or something else that we need to create. So in other countries, it is something else.
I've listened to some of the Australian sharings, and they really have like a full-time body almost, a manager to oversee this and roll out things. And that's not true for us as yet.
Yes.
Shall we then take Chong Kampui's question in the chat box? Okay, something technical, yeah. How do we determine that sample size that's required for an indicator? I do not know whether you shared anything earlier, Dr. Cindy.
No, I didn't. I cut my slides. And so
You can speak.
So in Singapore, this is what Dr. Pat shared. So they take a sample of about 20 patients, a sample size of 20. And if you look at the Australian Peacock quality projects, they also sometimes recommend just looking at 20. So this is quite a common practice internationally, and it is enough. So there's no sample size calculation because this is quality. This is not research. And so you don't need any sample size calculation. Does that help?
And piloting might tell us a bit more, yeah, on the feasibility
yeah.
Yeah.
I think these are some of the things that will be refined in the pilot.
Give us a bit more answers and direction. From your talk earlier, like I noticed you picked the indicator on opioids, access to opioids. I think it's a big thing, and in the community settings especially, right? So I'm thinking when services run into real day-to-day constraints, these are nice standards and then meeting our everyday practices. And then, I mean, once people get familiar with it, they'll see there's so many other things, but access to medicines is a big one, essential medicines, maybe staffing, maybe documentation and all that. How might services balance, holding that aspiration, those ideals of the standards without, and at the same time, they have these current constraints going on, not being too discouraged about that?
Is it me then?
Whenever you're ready.
I think if a service can't achieve this, there is nothing to be discouraged about. I think this is quite a common problem, and we recognize that. And so to me, the standards actually give you a louder voice. And so when you go for these meetings, or when you write letters to I don't know, the pharmacy side, right? To ask for access to opioids and all that, we can actually quote, standard number 12 says, and we need to achieve these standards, and these are, MOH endorsed standards. And so therefore we need help, resources, we need access to opioids in order to fulfill these standards. That has been published. And so it actually gives us a louder voice for advocacy. And in a way, the standards will be respected. People will listen to it, and we can actually use data to then say that, yeah, this is what we need, and you need to find a way to give it to us.
That's a really important point, actually, using this.
It is, some of the gaps will be internal, things that can be fixed internally, but some of them will be external, and that's when you wave the book and say, look, we need to have this.
We are almost at closing time, and I don't see further questions, so if I may just, something came up now. Some feedback. Content is essential, but the presentation really matters. This is Pick Wen. I hope I pronounced your name correctly. Feedback on the publication. Professional art direction could make the book far more accessible. That's something we've grappled with as well, I think, Pick Wen.
Yes.
Printing, the graphics, the design and all that. I really appreciate this feedback. It's so relevant to having something that people even want to flip through and look at and read in the first place, right? Thank you for that.
Yeah, I would agree, but we did face some limitations, and I know both you and Cindy tried really, really hard.
Yeah, from the colors to the font to the alignment, and still, and it is a very wordy document. So it's also good that you can pick out certain bits of it and look at that, if that makes it less daunting without having to read it from cover to cover.
And that's why I think for the future, for successful implementation, we'll be looking for more support so that it's not just busy clinicians doing the work on this.
So I'm just going to ask both of you perhaps as a closing, what would you say to a team that feels they're not ready yet to go down this path? Or to look at it? What might you say then? What would you say?
Okay. You might not be ready to go down the path, but please read the document. Talk to other services that have. Talk to the standards team. And
The emails are there for feedback.
maybe identify why you don't feel ready. Maybe you want to have some other things in place first, and that's absolutely fine. But when you do, you have our email addresses.
Yeah, I think that's a very nice summary. And so if your service doesn't feel ready for this, it's okay. It's okay. Keep joining whatever webinars we have. Keep listening out. If you don't have any personal experience of it yet, maybe listen to the experience of other people who might, jump into the water first. So sometimes I'm the person that won't jump into the pool first. I'll let someone else jump first, and if it's not
Test
too
the
cold, then
water.
I will jump in later. And that's totally fine. That's totally fine. Let's stay in this together because we did create this together, and let's continue on with this journey together. And take your time, I would say. Just stay in the conversation.
Thank you both so much. Thank you to Hospice as well for helping us to host this webinar today. I think some really nice discussions and thoughts, even reflections for us who have been sitting with the document for some time. And look forward to moving forward with this and hearing more from people. As Dr. Sylvia said, the email addresses are there. Please do share feedbacks, opinions, questions, clarifications. They're so important. And in the coming weeks, or 2026, perhaps the next few weeks, download the document, start reading it, start talking about it, discuss it. Thank you very much. We can close.